But I'm also the host for this presentation, which is being sponsored by the Educational Programs team, which I'm a member of. And today we have Dr. Nikita Maniar from USC here in Pasadena, their new offices.
UCLA.
Oh,
The other one. The other one.
Oh, my paper.
Blue and gold one.
How many days do you have left?
The other one.
Originally from Southern California.
Or signed. You already filled it.
Bite my tongue. Okay, read the paper, Wayne. Okay, so a little bit about Nikita. She's a board-certified neurologist and fellow of the American Academy of Neurology. She earned her medical degree at St. George's University and completed her neurology residency at the University of Missouri and Kansas City, or Missouri, depending on where you're from. She is trained in general neurology as well as management of special disorders such as Parkinson's, Alzheimer's, long COVID, and headaches. Prior to UCLA, Dr. Maniar held the title and role of medical director in the Department of Neurology at the University of Illinois, Chicago. She was also involved in a National Institutes of Health trial involving long COVID patients. Dr. Maniar grew up in South Florida, where she enjoyed playing basketball, biking, Indian classical dancing, and traveling with her family. She'll give us a sample of that Indian classical dancing at the end of the presentation. She's currently a part of the American Academy of Neurology and the LA Neurological Society. So I think we're ready to start. Now we have a transcription function going on here at the bottom of the screen. It's not perfect, but if perchance, if you can read it, it's recording everything that we're saying. So if you miss out on something, you can look at the screen and see if you can make it out. So it's important that only one person talk at a time. And I think that's it. So Dr. Maniar from UCLA.
Thank you, Wayne. And I'm really glad to have this opportunity to talk to you all about something that I see routinely in my clinic, which is dementia. So I'll be talking about the definition and types of dementia, the pathophysiology of dementias, risk factors for dementias, the importance of an early diagnosis, current treatment options, and the programs and services that are offered by UCLA. So jumping into what is dementia. So dementia is a decline in your mental abilities that you need for daily living. And it develops when there is damage to parts of the brain that's involved with learning, memory, decision-making, and language. Some of the symptoms of dementia can be cognitive, they could be behavioral, or they could be both cognitive and behavioral. Cognitive symptoms would be difficulty sharing thoughts, having memory loss, specifically dementia patients struggle with short-term memory loss, problems with following directions, and trouble with language. Behaviorally, they could develop agitation, anxiety, depression, have disorientation, irritability, hallucinations, paranoia, fidgeting, or sleep problems. So I'm going to be talking about the 5 most common types of dementias today. Alzheimer's disease, frontotemporal dementia, vascular dementia, Lewy body dementia, and mixed dementia. So the first one is Alzheimer's. What is Alzheimer's? It's a progressive neurodegenerative disorder that affects memory, thinking, behavior, and is characterized by a buildup of abnormal protein called amyloid plaques in structures in the brain. What are the risk factors for Alzheimer's? Age, head injuries, high blood pressure, diabetes, smoking, obesity, having a stroke or vascular disease, Down syndrome, depression, genetics, and specifically having this ApoE4 gene from both parents is a higher risk for developing Alzheimer's. Common symptoms that I see is when patients come in with their significant other or family members, and family members are saying they're constantly forgetting short-term information, recent conversations we've had, things that were discussed, forgetful of names and objects, having trouble coming up with the right word, ask a lot of repetitive questions, and they've become more stubborn and less flexible and lost motivation to try new things. What treatments do we have? Pharmacologically, we use the class of medications called cholinesterase inhibitors. This is donepezil, or brand name Aricept, rivastigmine, and galantamine, and other cognitive enhancers that I also recommend after getting blood work for a patient is either estrogen if they have low estrogen levels, vitamin B12 if they have low B12 levels, and then ginkgo biloba could be an additional supplement to take depending on their medical history, because that supplement also cannot be taken with certain medical problems. Antidepressants, I usually recommend they be referred to psychiatry or started on antidepressants if I see there are signs of depression, and antipsychotics if one is exhibiting symptoms of psychosis. The non-pharmacologic treatments, and I also recommend doing these alongside pharmacologic treatments, would be individual and group therapy if there is conflict with the caregiver and the patients. Having regular appointments with all of your doctors to make sure that your blood pressure is controlled, your diabetes is under control, cholesterol is under control. Having regular communication with family and caregivers. Environmental modifications. Sometimes dementia patients, they sundown later in the evening, so you want to make sure that when they wake up, the curtains are up, bright lights, not keeping them in a dark environment, and then making sure there's attention to safety, because these patients can veer off, go out of the house. So having one of those medical bracelets or an air tag, so family members know where they are at all times. The second type of dementia is called frontotemporal dementia. So as the name suggests, it's symptoms that affect the frontal lobe and the temporal lobe. The frontal lobe is involved in emotions, personality, executive functioning, and judgment. And the temporal lobe is involved in processes with language, sensation, perception, and memory. So the symptoms usually present with a combination of these two things. I usually hear from caretakers and family members saying that these types of patients are having more behavioral changes rather than memory loss. So they're acting inappropriately, or they're disinhibited and not really grasping information like they used to. They have a reduced comprehension of language, and they're making poor judgment. And that's when you want to explore this type of dementia. It's also more frequently seen in age under 65. Then we go to vascular. So vascular dementia, as the name has it, is due to uncontrolled vascular risk factors. Uncontrolled vascular risk factors are diabetes, high blood pressure, cholesterol, smoking, heart disease, and aging as well is an additional factor. Stroke is the most common cause of vascular dementia because when you have a stroke, your brain cells are deprived of oxygen, and that cumulative effect can start causing dementia by affecting different structures in the brain. You can also develop widespread small vessel disease, which affects the white matter of the brain, and the way you develop small vessel disease is by uncontrolled diabetes, high blood pressure, cholesterol, and all those other vascular risk factors. Vascular dementia has a sudden onset, but then the progression is more stepwise. So people who have vascular dementia will initially deteriorate, but then they'll be stable for a little bit, then deteriorate again, be stable, and deteriorate again. So that's the way that vascular dementia presents. The next is Lewy body dementia. So Lewy body dementia includes dementia with Lewy bodies, which is a special sort of disease that develops in a plaque, basically, that develops in the neuron itself. But this type of dementia is more prevalent in patients with Parkinson's disease. So it's usually seen mostly in patients with Parkinson's disease, where they develop these abnormal protein substances called Lewy bodies. One of the first signs of Lewy body dementia is usually when a patient is telling me they're having hallucinations. Visual hallucinations mostly, but you could also have auditory hallucinations. And they also complain of having spontaneous motor features. So they would have, some of them could be like kicking or punching in their sleep. They could have abnormal movements in their sleep of their legs, of their arms. And this progression could be rapid if not treated. And then you have mixed dementia. So mixed dementia is one type of dementia that occurs simultaneously with another type. The most common one I see is Alzheimer's dementia with vascular dementia, because most of the patients that develop Alzheimer's dementia also have uncontrolled blood pressure, diabetes, and cholesterol. So they end up getting vascular dementia as well. This was an important slide I wanted to discuss because, a lot of people come in extremely worried that they develop dementia. And just because you're forgetting things and you're misplacing objects, doesn't mean you necessarily have dementia. So there is something called mild cognitive impairment. And mild cognitive impairment is not a type of dementia, but it is a decline in your cognitive abilities and minimal changes that you see in your day-to-day life. So just because you're forgetting things or misplacing objects or maybe leaving the stove on and walking away and forgetting to turn it off does not mean you have dementia. But you should definitely be assessed by a neurologist. And in the office, we actually do a short memory test. It's called a MOCA, and it stands for the Montreal Cognitive Assessment Exam. And that test, depending on what you score, would put you either in the mild cognitive impairment, in the moderate dementia category, or in the severe dementia category. So it's definitely important to make sure that you understand that there is different levels to developing dementia, and not everything is dementia. And a person that does get diagnosed with MCI is at risk for developing Alzheimer's disease or other dementia. So it's extremely important to identify this early on and then mitigate the risks of progressing to Alzheimer's. And usually by mitigating the risks, you're controlling your blood pressure, controlling your high cholesterol, diabetes, and other comorbid medical problems, so it's not progressing to the dementia stage. What should you share with your doctor? So you should let them know if you've noticed any changes with your memory, language, attention, coordination, mood, personality, behavior, and judgment. You should definitely mention a time frame for when these changes have been seen. Things that you are now finding difficult to do that you previously were able to do. Any medications you're taking, prescriptions, and over-the-counter medications. I know everyone loves supplements, and pharma and advertising loves to market like all these medications that are going to magically cure your memory problems, but you really have to be careful what you're taking and read those ingredients and talk to your doctor about it, because a lot of the supplements could also affect other organs in your body like your liver and your kidneys, and you don't want to be injuring your liver and your kidneys by taking these supplements if they're not meant for you. You should definitely share any psychiatric history that you have, any family history. And I usually always ask that a family member or a caregiver come to the visit with the patient, because it's very important to get collateral information from the family member, since dementia patients have poor judgment and insight. They may not be able to provide as much information as we need. What pharmaceutical options are there? So I had mentioned this class of medications called cholinesterase inhibitors. So these are the medications that we use to slow down the progression of Alzheimer's dementia and vascular dementia. But remember, there is no cure out there for dementia. So you can take these medications, and if people have mild cases of dementia, maybe it'll help, increase their development of getting severe dementia by a couple years, but it's never going to cure the fact that they have dementia. New treatment for Alzheimer's disease. So I always get asked about these new medications, and although it's great that we're able to have new therapeutic options for patients with dementia, all medications come with side effects, and some of those side effects may not be worth it for certain people. So we do lecanemab infusions at UCLA. They're done at the main campus in Westwood. It's a IV infusion that is done every 2 weeks for 18 months, and then possibly they do maintenance doses. There are very specific criteria and eligibility for you to get lecanemab infusions, and one of the side effects that they saw in a couple trials that were done is there is a really high risk of developing brain bleeds and brain edema. So everything needs to be evaluated on a case-by-case basis, and we also have to weigh in what their labs look like. If you have some lab abnormalities with your cell counts, with your platelet levels, you probably won't be a candidate for this medication, and your chances of the brain bleed are going to be higher. Okay, so you're diagnosed, so now what? The first thing that I tell every patient of mine and their family member is, have you started the future planning process? Do you have a power of attorney? Do you have someone that's your healthcare proxy in the family? Do you have someone that you want to make medical decisions for you in the case that you're hospitalized and you're not able to make medical conditions because you're cognitively not with it? The other thing is, I've also had a lot of family members come to me saying they're very worried about their significant other, loved one driving. So I always have a patient get a DMV evaluation before I recommend that they continue driving. If they pass the DMV evaluation, I have no problem with them driving, but if they don't, then they would have to stop driving. And then medication management. I've had instances patients actually took too much medication, so then we've had to make sure someone steps in from the family or from an outside home health agency to help with medication management. So trying to get that sorted out. And then living environment. Having someone with dementia can be extremely stressful on the other person that has to take care of them. So you as a family need to come together and decide, is this something that you guys are able to do, or is there a skilled nursing facility or a nursing home that's close by where you could, have your significant other or loved one stay at and visit frequently? Because the living environment is very important in a dementia patient, because they could fall, they could definitely overdose on medication. So you some that get to the point where it's very severe might need 24/7 supervision. And what services do we have at UCLA? So we do have a Alzheimer's dementia care program, and like I said, we also administer that IV infusion medication if you qualify for it. So the other services that I refer a lot of my dementia patients to are speech and language therapy, cognitive therapy, physical therapy, and for clinical research. So the number below is to make an appointment, if you would like, with a geriatric medicine dementia care specialist.
Where's the number?
It says right there, call.
Oh,
Do you see that?
not really.
Oh,
Can
okay.
you just read it out?
Sure. Maybe I could make it bigger? Does that make it bigger?
It's 310.
Okay.
Thank you.
You're welcome. Okay. And you could definitely call them and try to get in. But again, like every healthcare system, there is a wait time for everything. So if there is a significant wait time, you could definitely talk to your primary care doctor or a general neurologist like myself. In the meantime, until you're able to get in to see a dementia specialist, and I could start that referral process, or your primary care doctor can start that referral process in the meantime. And that's all I have for today.
Oh, that's enough.
Scared everybody.
Yeah, she did.
So now we'll take questions.
You skipped a slide.
You skipped a slide on the shingles vax.
Yeah.
Oh,
Yeah.
I'm sorry.
The shingles
Yes,
vaccine.
you're right. Okay, let me just comment on
She's
that.
a tough crowd.
they look at everything. That's good. I'm glad you keep me on my toes. So current research on treatment and prevention. So there's research right now being done to look at the shingles vaccine, if it helps reduce the risk of dementia. And that's because the herpes zoster virus is actually linked to a lot of other neurologic problems. It can cause facial neuralgia by attacking the facial nerve. You could also have some neuropathic pain. So I think that will be really helpful in helping reduce the risk of dementia. The other research that has been done, which has proven to be effective for prevention of Alzheimer's, is the relationship between blood vessel health and brain health. So if your blood vessels are healthy because your cholesterol is controlled, you're not a smoker, you're not drinking heavy, your high blood pressure is controlled, then the likelihood that your brain health is going to be good is very high. There's also research being done on an intranasal insulin medication that they say is supposed to help prevent dementia, but again, this is still in the pipeline of research. And then researchers are also looking at targeting the beta amyloid protein plaques in the brain. And the medication I mentioned earlier, the lecanemab, which is the infusion, this one, it actually helps target those amyloid plaques and remove them. And that's why it is effective if you meet criteria for treatment. Yes?
What does that mean? Approved by Health Canada, not available in SK.
Oh, I think I got this from another resource, so I think it's just saying that it's not available in other European countries. So mainly it's available here, available in Canada.
Maybe that means Saskatchewan.
Saskatchewan, yeah. Mm-hmm.
Does vascular dementia, does that also include brain shrinkage?
It does, but not as much as Alzheimer's. So vascular dementia actually affects the blood vessels in the brain. So it causes damage to the blood vessels, and the blood vessels decrease how much oxygen and blood flow go to the brain. But in Alzheimer's, you actually get more shrinkage of the brain. But vascular dementia doesn't cause dementia by shrinking the brain. It's more because the blood vessels are damaged and there's decreased blood flow and oxygen to the brain. So the brain's health has deteriorated.
I've been told that it's normal to have brain shrinkage.
Yes, I was going to bring that up. As we age, our brain does shrink. And so I always order an MRI scan of the brain because I can tell looking at the MRI brain scan how much your brain has shrunk. In Alzheimer's, you see more dilatation of the sulci and the gyri, which are the coverings of the brain. And so if it's significantly dilated, then that's not like normal. And usually the radiologist, when they read it, if they see that the changes are more significant than the patient's age, they will comment on the report and say that the atrophy, which is a fancy word for brain shrinkage, is greater than expected for the patient's age.
But does that mean that as we continue to age to 109 or 115,
Your brain is going to shrink, yes.
Dementia.
There's an optimum.
But it doesn't shrink to the point of dementia. It just slightly shrinks as you get older. And that's why when I have patients who are elderly come to me saying, I used to be sharp as a tack when I was 30 years old, and now I'm 70, and I'm like, well, as your brain ages, it shrinks, and you lose some of that memory processing. So that's normal. That is normal. Yeah.
What is the cognitive therapy that you were talking about with this phone number?
Yes.
What does that entail, the cognitive therapy?
Good question. So cognitive therapy is done by our speech language pathologists, speech language therapists. So they went to school for speech and language therapy, and they do brain teasers, puzzles, memory games. So they'll do a lot of cognitively stimulating testing with you, and then they'll keep a track of how you do when you initially come to see them. Then they usually do about 12 to 13 sessions or more if needed, and they'll constantly keep a record of how you're doing, and then I get access to all these reports, and it helps me because then I can see if patient is actually doing better, or are they going in a backwards direction. So that's the type of thing they do in cognitive therapy.
And then when you review those results, what kind of options for therapy? Is it all drugs? It helps you determine which drug you might use in which patient.
Depending on which dementia they have. So Alzheimer's, vascular, usually we use the same medication. Lewy body is a different medication. Frontotemporal dementia is a different medication. So once you know which type of dementia someone has, that's what the treatment is based on.
And then the cognitive therapy lets you know how bad the condition, or what's developing.
It lets me know how the patient is doing and whether this person needs 24/7 supervision, or are they capable of living on their own and functioning independently, because the cognitive therapist is telling me that they're consistently improving and doing better. Okay. Yeah.
One of the things when this program was advertised about, things that you were talking about of this were headaches of this, and nothing was mentioned about chronic pain in the front of one's head. Is that a symptom?
I don't usually see headaches with dementia. I think headaches are maybe, headaches can be due to a number of things, but one of the reasons dementia patients could have headaches is if they're not sleeping well. So if their sleep is interrupted, they're not getting a restful night's sleep, or if they're obese patients and they have obstructive sleep apnea, which hasn't been diagnosed, they could get headaches. So it's not usually like one of the symptoms of dementia, but it could be a part, like a secondary symptom that you experience because of lack of sleep or having obstructive sleep apnea.
Thank you.
Does Parkinson's fit into dementia or only through Lewy body?
Only through Lewy body.
The various dementias you've mentioned, they're all progressive?
Well, some of them are, some of them aren't. So vascular dementia ends up starting very rapidly, but then it stabilizes, and then you decline again. You could decline again, or you could just stay, at the stable state that you are.
And Alzheimer's is progressive?
Alzheimer's is progressive, yes.
And does that involve the destruction of parts of the brain?
It involves the buildup of that amyloid plaque in different parts of the brain.
Does that eventually result in the loss
of neurons?
And you see this with the scanning systems, or scans?
Yes, there is a very specific scan. It's called a brain PET scan, and that's the scan I order if I'm looking for plaques.
Are there recent breakthroughs in research?
The most recent research uncovery has been the lecanemab that I talked about, the IV infusion, but it's been very tricky because a lot of these medications come with side effects.
Is the lecanemab the one that has a negative effect on people who carry a copy of this report?
Yes, yeah. So that's why you have to meet eligibility criteria for it. Okay?
Three quick questions.
Sure.
One is, I don't know if you're familiar, but on the internet, there was an advertisement by Bill Gates about a prevention for cognitive decline. I mean, it was $299 for 299 for 180 days of pills. And, you know, Clint Eastwood now could remember lines, and Denzel Washington. And so, I mean, I listened to it, you know, but I didn't click because I, you know, it could be a scam. So just, have you heard of that?
Thing.
You
I
saw
think
it
that's
too?
AI generated, because I don't think it's really Bill Gates.
Yeah, see, that's what I think. It was blueberry stuff and honey. So I was wondering, one, if you're familiar with that.
If you watch it closely, you'll see that isn't quite Bill Gates. It's very convincing. He identifies as Bill Gates, but you can tell that's not a real human being. It's really a fake Bill Gates.
So
Yeah.
anyway, it's a natural, but I mean, he was selling it.
Yeah, I mean, I think I mentioned this earlier because I get lots of patients who come to me saying, oh, I saw this advertisement and, you know, they had like Clint Eastwood or, you know, someone else on the picture. So you have to be careful with these supplements. You really have to read the ingredients in there. And 99.9% of the time, these supplements are just made up of vitamins, like vitamin B12 or blueberry extract or some sort of extract.
It was honey.
Or honey,
Blueberry
yeah.
skin.
And those vitamins are not going to work like this. And they're not going to do anything magical for you. Yes, maybe you would have a little bit of boost in your cognition because vitamin B12 is a nerve regeneration factor. It helps regenerate nerves and neurons in the brain, but it's not going to do anything magical for you. So I always tell patients to heed with caution, and you should really get your levels checked as well before you take these supplements. I wouldn't take it without consulting with a physician, whether it's a neurologist or a primary care physician.
Second quick question, if say a parent, my mom had advanced Parkinson's, does that make you more likely to have some sort of brain, you know,
Yeah, if it's advanced, then yeah, like are we talking, is she wheelchair bound? Is she require assistance with all?
She did.
Okay, yeah, then
She's
it could.
passed, but,
Mhm.
so does that kind of go to the next generation? I mean, we're more likely if we had a parent that had that?
Not necessarily in this day and age. So maybe like 20 years ago, a lot of these neurodegenerative diseases, Parkinson's is a neurodegenerative disease, was linked to genetics. But in the recent 4 to 5 years, actually these neurodegenerative diseases are more environmental. What we eat, where we live, our day-to-day activity, if we're sedentary or we're active. So your chances of developing these neurodegenerative conditions is not purely genetics anymore. It does make a difference on your environment and the things that you actually consume.
And the third quick question is, I'm assuming exercise, eating
Yes.
healthy, do you recommend other things if we haven't been diagnosed, but we notice
Yeah.
there's no way I could take the GREs now, you know, I would flunk, but back then you could, you know,
Yeah.
what's the problem?
Good question. Yeah. So I recommend, or at least the Alzheimer's Association and ANN and all of these Neuro Academy websites say 30 minutes of aerobic exercise a day is really good for brain health, whether it's walking, jogging, swimming, aerobics, water aerobics. 30 minutes is the ideal amount that you should be doing to help with your brain health. And then the other thing is cognitively stimulating exercise. Crossword puzzles, regular puzzles, Sudokus, reading and having active discussions like a book club, watching the news and discussing it, those types of things would cognitively stimulate your brain and help with brain health and development of new neurons. Yes.
I have a doctor friend who thinks that lithium orotate might be useful in preventing problems, dementia. Have you read about that at all?
I have not. I mean, lithium is a pretty heavy
But it's
medication.
orotate, it's not the one that's used.
Oh, it's orotate, okay.
Orotate.
Yeah.
Supposedly there's a group of people in the tip of South America
Oh.
that have that mineral in the soil, and they don't seem to have the same level of cognitive problems.
I mean, it could be possible. There hasn't actually been research done on lithium orotate specifically, but they do also recommend a Mediterranean diet is really good for preventing Alzheimer's or dementias. So that has validity and research-backed science, but I haven't heard of any trials about lithium orotate. Yes, in the blue jacket.
So I'm wondering, I come from a family where everybody gets Alzheimer's disease.
Uh-huh.
So I'm wondering, and I feel like I'm not there yet, but it would be nice to know when it's gonna come on. So is there a branch of medicine that kind of tracks you, that you can go to and be tested, or just keep track of how you're doing mentally?
Your primary care doctor actually should be checking you when they see you for a wellness visit.
Yeah, I mean, he has me drawing a clock face.
Yeah, that's-
By the time, when I can't draw a clock face, I'm pretty far gone.
Well, no, there really isn't anything that, I mean, you could be your own judge, or your family member could be a judge of
Yeah, I don't
things.
have family here.
Okay.
I mean, that's what the village is.
Yeah.
It's- Do I, Jess, what are you
There we go. You could have an accountability buddy who just does a check-in every 6 months. You could definitely reach out to the Alzheimer's Foundation. They might have nurse visits or someone that could do checkups, but usually there's no special physician or anyone that you would go to just to get evaluated and see if you've progressed or not. It's more through that clock drawing test that we determine, how you're doing. Yes.
You mentioned that people who've been diagnosed with mild cognitive impairment are at greater risk for developing dementia. Are there statistics as to how much of a greater risk?
Yes, they say between 40 to 50% are at risk. But it's also, in your own destiny, as in how you live your life. If you're extremely sedentary, you have all these uncontrolled risk factors like blood pressure, diabetes, and high cholesterol, then you are going to progress to developing dementia sooner. Yes.
You mentioned the Mediterranean diet, so I think they're still doing research on the MIND diet, which is specifically tailored towards Alzheimer's.
Yes, that is the other one which they're still doing research on. MIND, MIND diet.
What is that? I couldn't hear it from you.
The MIND diet, MIND.
Okay.
You could just look it up, and that's another one that's correct for prevention. Yes.
I have a mother-in-law who died from Alzheimer's, and early on, I always wondered because she started having these weird dreams, her dreams changed, and then she began to believe that those dreams were reality, and I wondered if that was an early sign of Alzheimer's.
It may not have been an early sign of Alzheimer's specifically, but definitely a sign of dementia. And I don't know if she was formally diagnosed, because visual and auditory hallucinations like that can be seen in frontotemporal dementia as well. So there's a possibility maybe she had frontotemporal dementia that had developed.
Don't UTIs also cause hallucinations and?
Yes. And that's why whenever I have a patient come see me I order 5 things. Low vitamin B12, like extremely low B12, can cause memory problems. So I order a B12. I order a B6, folate, urine sample to make sure this is not a UTI, and a syphilis test. And I've had 80-year-olds who tested positive for syphilis. So I don't take my chances. I order these tests for everyone because these things are reversible and easily treatable, and it would be silly if it went missed.
My wife had a blood test of the plaques, the tau and the M, and she came out negative. How far in advance does that predict? I mean, in a year from now, could she suddenly become positive? I mean, if it's negative, does that mean she has a long time before it might become positive? Or could it?
No, it could still become positive, so you would just, there's no time frame on this. It's very hard for me to pinpoint a time frame because everything's neurodegenerative and, you know, it changes, your body changes from day to day. But yeah, the Quest Diagnostics actually has a Alzheimer's screening test. I don't know if it's covered by Medicare or most insurances. Sometimes, you know, if there is family history and your doctor puts that in the diagnosis when they order this test, then you could probably get it covered. But they test this amyloid and tau protein and see if your blood is positive for those proteins. So.
You use the term sundowning. Can you tell us what that is? For those who don't know?
Sure. So sundowning is a term they use when dementia patients or patients who have altered sense of awareness get worse once the sun goes down because there's not light outside. Usually I see this more in people who get admitted to the hospital that are elderly because they're in an unfamiliar environment. They're being woken up every 2 hours by nurses to get a blood draw. And so they end up getting delirious in that hospital stay. And it's worse when the sun goes down or when there's no light out. Yes?
In his book, My Father's Brain, the author said that at end stage, all these things seem to be very similar. You can't tell one from the other. Is that a profound statement or just an ordinary statement?
No, that has some validity to it. I agree because when you get to the point where someone is wheelchair bound, they're barely talking, they're not able to take care of themselves, you know, it's very difficult to know if, you know, they have an underlying infection that's making things worse. A lot of those end-stage dementia patients I have, they're extremely stubborn, they don't want to get blood draws, they don't want to take any medications, they just like to be left alone. And so in that instance, I always ask the family member, you know, what do you want? Do you want to continue pushing your loved one or significant other to doing things, or do you want them to just live the rest of the life that they have left? So I always try to optimize quality of care, and I think, like you said, when it's that severe and significant enough, it's hard to exactly tell what is getting worse. Is it dementia that's getting worse, or is it underlying infection that's making the dementia worse? Is it they're delirious, you know, other factors? Yeah.
You didn't mention anything about suicide prevention, because as someone is experiencing this who lived a full, rich life, and we're all very aware of the research and the stories of this, they can clearly see what their future looks like, and that becomes a concept that I'm sure they embrace. What do you do with this? How do you handle that?
Yeah, I mean, that's a very valid point, and I'm glad you brought it up. My nurses, before I go into the room, they do this PHQ-9 screening, which screens for suicide risk, for depression, for any of those symptoms. And if they score high on that questionnaire, I automatically send a consult for them to see psychiatry. And so then I'm getting psychiatry involved, and I'm making sure that they have access to mental health resources if they need. So that screening is automatically done for every patient in our clinic by our nurses. Yeah. So they will get access to mental health resources and providers, if that's a concern. Mm-hmm. Yes.
I was gonna ask about Lewy bodies because I understood that you had no way of monitoring or knowing that it was Lewy bodies. It doesn't, spinal fluid or.
That's right.
Does it have it?
No, it doesn't.
No.
So it's more
in other words,
symptom.
You gotta have direct access to say, oh, that's Lewy bodies.
Right, like you wouldn't know until you did an autopsy, essentially. But that's why we go based on clinical history, clinical exam. And Lewy body has been linked to Parkinson's disease. So if a patient has Parkinson's disease, which does have a way of being diagnosed, then, and they're presenting with hallucinations and having memory problems and having gait disorder, then it's most likely that it's Lewy body.
And it's important to sort of differentiate and make sure.
Yes, absolutely, because the treatment, you want to treat your Parkinson's symptoms to help with the Lewy body dementia. Yeah. Anyone else?
Is there a range or a time frame for deterioration once you think it's Alzheimer's or decided it's Alzheimer's?
No, unfortunately there isn't. Like, I've seen patients get diagnosed and stay extremely stable, and then I've seen people diagnosed and then actually go down like that. Because it's neurodegenerative and it's progressive and it's really on your body's health. So it's very difficult to predict. I mean, some people do great and some people don't do great. You can't predict like, oh, they only have 10 years to live. It's you just can't do that prediction. Yeah, that is a long time.
Is there any relationship between intelligence and, I'm thinking of two people I know who, well, they had advanced degrees and in their middle to late 50s, they had to leave the workforce because of dementia. Is there any kind of relationship between like intellectual ability and?
Only if they have been diagnosed with Down syndrome. If, you know, they had a diagnosis of Down syndrome, they had intellectual disability, then the chances of developing Alzheimer's is high. But just pure intellectual disability or inability is not.
No, these people were really, really bright.
Okay.
And the opposite of, and they had advanced degrees in science and in accounting, and so and yet in their 50s, they had to retire.
Yeah.
From for the most part, from their intellectual responsibilities.
Yeah, and that's not because of their IQ or anything. That's just because they may have been I've seen people actually in high stressful roles, CEOs, COOs, managing very large hedge funds that have crashed, that have had to leave their job in a high position because the stress on a day-to-day basis actually affected the deterioration of their brain.
Okay. Thank you.
Mm-hmm. Yeah.
You mentioned MCI.
Mm-hmm.
Does it, with time, automatically or inevitably progress to some form of dementia?
No. I had mentioned that it's really dependent on your health and how you take care of yourself. So if you continue to stay active, eat healthy, mitigate all your vascular risk factors and keep your blood pressure, cholesterol, diabetes under control, there's a low likelihood that you would develop Alzheimer's.
I was talking to Marlene's example of the two people. I thought maybe it was early onset Alzheimer's. You want to say something about that?
Sure. Yeah. So there is early onset, which is usually 60 and below. Like I usually see it more in younger patients. And then late onset usually develops, I've seen 70 and above. So the example you gave of your two friends or the people you knew, they had the early onset, and that could have again been, I don't know if there was any family genetics involved, but stress plays a huge role in it. Genetics plays a huge role in the early onset development, and your vascular risk factors play a huge role as well. Yeah. Does that answer it? Okay. And someone else, I think, sorry, she had a question, yeah.
This whole thing about amyloid.
Yes.
I've been reading a lot, that people are, into their 80s, 90s, they're spry, no indication of any dementia to speak of. And for some reason, they have an autopsy, and they have a lot of amyloid. So they haven't really figured that out yet? Is that what I'm reading?
I mean, there is a special scan I mentioned, the brain PET scan. So that brain PET scan would show if there is amyloid buildup. So if there was high suspicion for it, their doctor should have ordered the brain PET scan. Like, you don't have to wait until an autopsy to find out if you have amyloid. You could get this special brain PET scan where they put in a radio tracer dye and those amyloid plaques light up on the scan.
But it sounds like,
that they didn't have any indications, that they had any dementia whatsoever.
Oh, I see.
And then, for whatever reason, they had an autopsy. I've read this numerous times.
Yeah.
So they're not 100% sure.
Or did that person have a lot of head injuries?
I don't know.
Okay.
I've read it. Has
Oh,
anybody
you
else
read?
I've read this many times.
So there's CTE as well, which is chronic traumatic encephalopathy, and they also get amyloid buildup. So football players, boxers, all these people that have head injuries, they don't end up showing signs until a lot later, and then on the autopsy, it gets found that they had these CTE changes. So sometimes it could be silent things that go unnoticed, and then you find out after the autopsy, unfortunately. Yeah. Yeah.
Is amyloid buildup, can you do something to retard it, or no?
You could take these medications to prevent further buildup, like the cholinesterase inhibitors. But the lecanemab is the only one so far that does the removal of the plaques. And the new research that's being done is trying to target how to remove these plaques.
What sort of cost are we talking about? I assume that a lot of this, wouldn't be covered by insurance policies.
It depends. It could be covered depending on your diagnosis. I think the infusion is like $40,000-$50,000. So it's an expensive drug, yeah.
Okay.
So there would need to probably be a lot of documentation, and then see what the insurance would cover. But unfortunately, yeah, it might be difficult to get covered.
Okay.
Yes.
My wife has dementia, and she's okay in the present moment, pretty much, but she's total loss of memory. Is there any point in going through a bunch of brain scans and trying to figure out exactly what's going on in the brain there is?
Yeah, there is. I mean, she should definitely at least have an MRI scan of the brain so we know what her brain health looks like. Is there any shrinkage? How much? Is there any other things going on in the brain?
But how specific would that, on MRI, what would it tell you? I mean.
It would
is
tell us,
differentiating?
it would tell us if she had a lot of vascular disease, then, you know, does she have vascular dementia versus the other type? It could tell us how much the brain has shrunk, if it has shrunk.
But in terms of therapy, based on the MRI, is it useful?
Not for therapy, but it is useful for making sure we have the right diagnosis and the correct treatment.
Well, that's, I mean, in terms of treatment, there are treatments that
Like, not to cure dementia, remember, there's no treatment to cure it, but there is treatment to prevent it from progressing. Yeah. Anyone else?
What percentage of people do you expect to get dementia?
That's a really good question. You know, I can't answer that again. I wish I had a magic 8-ball that would give me that information. But unfortunately, we all have different bodies and we all take care of our body differently. I would say that like the percentage of people with dementia in the past 5 years has significantly gone up because of the processed food that we consume, because of the lack of exercise during COVID, like people were just sedentary and drinking. So I think those factors definitely cause the number to go up, but I wouldn't be able to predict exactly how many people are prone to getting dementia or have dementia currently. The Alzheimer's Foundation is a great resource for all of this because they actually send out censuses and they do polls. And so they look at everyone in the entire United States. So they would have all the numbers that you probably are looking for. But I know the food environment and the way that we take care of our bodies has changed significantly from like the past 5 to 10 years. And the numbers are going up because people are just not being healthy with their lives or making healthy decisions.
Yeah, I have a relative who, she drinks a lot, and she was visiting me recently, and so tell me, can you talk about alcohol on the body as far as dementia is concerned?
Sure.
She's 85, she seems okay, but
yeah.
Could you discuss alcohol?
Yeah,
consumption?
so alcohol
On dementia?
definitely causes impairment of the central nervous system. It, you know, brain cells definitely get affected in the process of consuming alcohol. When you're younger and you're consuming alcohol, you could regenerate new neurons quickly. When you're older and you're consuming heavy alcohol, heavy as in having like an 8-pack of beer every single day, that's heavy in my opinion.
What if you're drinking, let's say, a bottle of wine and a half?
Every day?
Every day.
That's a lot.
Okay. And
one glass of wine a day is normal.
No, I'm talking an entire bottle a day. Yeah. So, but she's pretty amazing for 85 so far. So I'm wondering, where's this gonna lead? You know. So it's not good.
I mean, she might be amazing, but her health at some point is really gonna start deteriorating. I would not recommend drinking that much wine in a day if you're 85. I don't like restrict any of my patients from drinking. I think it's okay to drink if you're doing everything in moderation.
Which would be what, like one
glass
at the most.
At the
yeah,
most.
I can't imagine.
1 glass a night. Yeah.
So
a bottle and a half
a day.
Yeah.
No, a bottle plus go out for dinner, another 2 huge glasses, and so yes. So I was quite alarmed. So she was holding on to me a lot when we went to the Huntington, but we walked for like 12,000 steps. She's
Yeah.
85, I'm 72, so there's a big difference there.
I agree.
But
yeah.
my husband and I were like, very functioning,
Yeah.
still working,
Okay.
amazing, yeah.
Yeah.
Her
Wow.
own business, but she lives in New York.
She has really good genes then.
Yeah, her mother lived till 100. Okay.
Yes.
What's the name of the organization again, the Dementia?
Alzheimer's Foundation.
Oh, it's
Yeah, the Alzheimer's Foundation, yeah. They also have really good resources for any respite services. So if you need food delivery or in-house care, they usually help with arranging those types of things for you. So I refer a lot of my patients to the foundation because they have some great services for caregivers and for patients. And usually they have local chapters in every state. So you could definitely find that information on their website. Mm-hmm.
Are they the ones who have the, I guess it's a list of suggestions, so that you can go through, if I have dementia, type conversation with your kids or your family?
Yep.
Are they the ones who have that?
Yes, they do. Yeah. And is there someone else?
Any other questions? Going once? Twice? 3 times.
Thank you very